I will tell you a little about my work, as Alessandro has already introduced. I already saw some comments in the chat box. I don't really have time to write things down, so please feel free to contact me. I have my email here, so feel free to write me with whatever. So I'm just going to go a little bit about the background for where I work and why we think that these design thinking approaches are relevant in our research group and projects. And then I will share some examples from our work, and then some challenges on the way, and open for a discussion. And I have made plenty of room in the end, so we can get a discussion going, which I'm looking forward to. So as Alessandro also already said, I have quite an interdisciplinary background and have covered both humanities and social sciences and science. So I know a little bit about different ways of approaching science in various ways. I learned about design thinking in my PhD, where I worked with co-design approach throughout my project, and where I was a part of developing an exhibition on health in a science center here in the Copenhagen area. And I was responsible for engaging families and exhibition designers in this joint venture of creating an exhibition where health was communicated joyfully and where you could experience health. So that was really interesting. And working with the design thinking and co-design was for me like a missing piece in my research. Because I have always worked very ethnographic and qualitative, but I have often missed approaches to take the insights from these studies further. So not just document issues of concern, but also take it further in a more solution-oriented mindset. And I'm currently based at the Faculty of Health in University of Copenhagen, where I'm part of the Center for Healthy Aging. And this is quite a big cross-disciplinary center, working with the gerontology from multiple perspectives. And the vision is to produce knowledge that can empower people to live longer, healthier, and more meaningful lives. So it's quite a big vision, but there's loads of different projects going on, so it's worth diving into. And I'm part of the Christiansen group under Associate Professor Maria Christiansen, who has done a lot of research in person-centered care and aging. And I think I will change to the next slide. So why apply these participatory approaches and design thinking? Well, for us and for me, I think it gives the opportunity to work with citizens as participants rather than just informants. And citizens are really viewed as active agents, that they have a say. And it also forces you to challenge your own assumptions and embrace uncertainty in your research. And it also twists your role as researcher, rather than being this to be a participative facilitator rather than just an objective spectator. So in my research, I always try to focus on applied research that is produced in this everyday life context with the ordinary, lack of better word, people that are relevant to practice and in one way or the other. And I try to include professional stakeholders and citizens in research design and do this more holistic approach to complex health issues. So I think in these studies, context is vital. And context is in health intervention studies becoming a hotter and hotter topic, if you can say that, because how can we take successes from one intervention and apply it elsewhere, and can we do that? So I think here design thinking offers a toolbox for identifying which parts of research-based health interventions are generic and which parts are more context specifics. So it can be a help to translate knowledge or to adjust the chosen methods. And it's also a way of making a research process a mandatory part of the results. So this focus not just on the results, but also on the whole process behind it. So the first example I will just briefly touch upon is the study that was based on this, that led to this publication. I have lots of lovely pictures from it with many people showing me their medicines, but in these COVID times, I can't access the database where it's where they're saved. But basically, we tried to apply these 3 phases of innovation from a human-centered design. So we had an inspiration phase where I went out and I visited elder multi-morbid citizens. So it was kind of like getting them to show me their everyday routines concerning medication, to get a more detailed view into this polypharmacy issue. And we really tried to get stakeholders involved in different exercises afterwards of affinity mapping and finding shared ways forward in this issue of polypharmacy. And then the second example that I will spend a bit more time on is the project STRIT in Danish, which is the Danish acronym for Health, Wellbeing and Social Relations in the social housing area. And it's a project that's led by Professor Rikke Lund. The social housing area that we are investigating is undergoing physical changing and massive demolition. So it's really being restructured, and the different kinds of ways of owning your home is changing. So instead of just having social housing, there will also be houses that you can buy, and so this more diversity in the ways of owning your property. So the study, you don't have to spend a lot of time understanding the study outline. It was just to give you the big picture. You can read the protocol paper that's on the bottom here if you're interested. So the study has a quantitative strand and a qualitative strand, so to say. So it includes data from 3 survey waves in the local area among residents aged 45 and above. And it has several collection of qualitative data, first among 31 residents with Turkish and Danish background. And basically it works with these register-based studies also, that is quite unique for Denmark, because we have the social security number where basically everything we do is registered. So if you have my number, you can see all the diseases I've had, all the medicine I've taken, all the library books I've rented, the schools I went to, my income, my job situation, my taxes, basically everything. So you can make a lot of cross analysis from these data. And I'm part of this intervention studies, so the yellow line at the bottom. So we had intervention 2 that was supposed to be this year, but like so many other things this year, it had to be cancelled, but I'll touch briefly upon that. So here you can see a couple of pictures just to give you an idea of how it looks. The social housing area is very diverse in ethnicity, but the Turkish minority is by far the biggest minority group in the area, and many of the elderly Turkish residents came to Denmark in the 70s, and the men worked, for instance, in construction business, and their wives were at home. So especially the women therefore lacks Danish skills, and some of these immigrants are also illiterate. So this makes them quite difficult to contact also. And today they're part of the first generation of minority elders in Denmark, because Denmark is traditionally quite a homogeneous society. So in the 70s, we had like these first big waves of migration to Denmark, and they're getting old now. So it's the first time that Denmark as a society and as a health system have these people with migrant background. And many of the elders from this area suffers from non-communicable diseases and multi-morbidity, and as such they constitute a vulnerable group of older adults in Denmark. So just to give you a tour through the two interventions in the project, a colleague of mine had made a lot of interviews, these 31 interviews, and we had a lot of information about the residents from the survey studies. And intervention 1 was then developed with the 23 local residents at a workshop in the community cafe. And I apologize for the drawing being in Danish, but it's not really important that you see what it says, but just to give you an input at how it looked. So the workshop was facilitated by us researchers, and also by our household, almost at this point, graphic facilitator Mette Jeppesen, that we have worked with throughout this project. And you can see here that that the residents made these many ideas for activities that she all drew, and we all decided that the intervention focus was to enhance social relations among all residents through health promotion activities that were community-based, participatory, and diversity sensitive. So it was very important for the residents also to interact across ethnicity, because as it is now, the Danish Turkish people talk with each other, the Danish Pakistan people talk with each other, the ethnic Danes talk to each other, but they don't really mix, even though they're neighbors. So that is like one of the big issues out there, which is by far not uncommon, and I think it's like that everywhere. So the winner idea for intervention 1 was social outings to different sites and locations for residents above 45 years. And the purpose of these outings was to establish relations to fellow residents across ethnicity and gender, and to create a sense of cohesion. So you can see it's like in the middle, to the bit right of the center, there's a bus with a big 1. So basically we organized bus trips outside of the community for the residents, and we went to on these 4 bus trips in last year, and you can see on the one side it's from a Christmas market, and then the other side we went to on a moose safari, which was quite exotic and a lot of fun. And the residents afterwards, after all, we did a lot of evaluation on the bus trips, and they all reported that these excursions had provided them with a better understanding for each other, especially across ethnicity. One example is when we went on this Christmas market, it was quite a long trip. So some of the women from the Turkish minorities offered to make lunch for everyone. because the ethnic Danes were like, well, we don't know what you eat, so it's difficult for us to make anything. And they were like, well, don't worry, we'll make it for everyone. So the mamas just reunited and just cooked a lot of the Turkish dishes. And then everyone ate together, and they were like, the ethnic Danes were like, oh, this is really delicious. How did you cook this? And it was quite a nice moment there. And they also said that they felt they had gotten to know more people in their community, and the bus trip gave them an excuse to say hello to each other when they met in the community, and provided an issue for conversations. So in intervention 2, it was meant to be an iteration on all of this, and we had basically designed it to that the residents could, in 4 workshops, learn to draw, and basically the focus would be to produce community narratives and give a population that is often silent in the public debate, and even often stigmatized, a possibility to tell their own stories. But this was sadly cancelled due to COVID-19. So in light of the pandemic, we had to resettle. I don't know if you can say that in English. We had to do something else. And we could see from the numbers that COVID was spread rapidly in the social housing areas, and especially among Danes with minority backgrounds. So therefore we began a collaboration with our network in the community, and again Mette, our graphic facilitator. So we carried out 4 focus group interviews with elderly residents with the Danish, Turkish, and Danish Pakistan background. And we analyzed the interviews, and from this, Mette made these 4 narratives of everyday life during the pandemic. And all the material was validated by the participants, which you can see on the bottom picture here. So they had a chance to give their inputs to it, and to say this should be a little bit different, or no, we didn't really mean this, or I don't feel comfortable in this being shown, could you take it out? And from this project, we have made a book with the 4 narratives that is this close to being finished, and 5 posters with the Corona advice. And very soon we will also be ready with some small explainer movies for social medias. So on the one side, you can also see some of the pictures that Mette, our graphic facilitator, made, where this one couple told us that even though they found it hard to be isolated in the COVID-19, they tried to make use of the time by exploring new recipes in the kitchen. But at the bottom, you can also see that they had they worried a lot for their families and home countries, and the health of them, and when could they see each other again. So this stressful time. So this is, I'm just going to show you all 5 of our Corona posters, because it communicates this good Corona behavior, and was chosen based on what the residents found important. And therefore they all start with our best advice for you is. So it's something different from the classical pictogram illustrations, and they focus on things that you can do rather than actions to avoid, basically. And they show people of color, and they have also in the bottom corner a QR code that directs you to information on COVID on various languages. So I'm just gonna tell you, the one is our best advice to you is to talk on the phone with the people you care for as often as you can. And the other one is our best advice to you is to stay at home if you have the slightest symptoms. And then the next 3 are our best advice to you is to isolate yourself if you're ill. And the next one, our best advice to you is to wash your hands as often as you can. And then the last one, our best advice to you is to see your friends, but be outside and remember to keep distance. Yeah. So we've gotten a lot of positive feedback on the posters so far, and we're trying to get them out there as much as possible. And the next couple of months, I will use to take the vast material we have and use this visual material to redesign it into a dialogic tool to public health workers and social workers, that they can use in dialogues about mental health with older adults with minority backgrounds. So I'll interview a range of professionals because I can't really do my ethnographic thing in these pandemic times. So it'll be interviews to hopefully make a product that is research based and ready to use in practice. So crossing our fingers for that. And I think working with these graphic visual methods has really provided us with a wide range of advantages in the project. It's provided us with an accessible and shared platform because, I mean, drawings of everyday objects are understandable across language barriers. So if you draw a house, it's understandable even though your mother tongue is Urdu, Danish, or English. So you can communicate much faster or easier. And it also creates this physical workspace or product, this tangibility thing. And in my experience, that enables more personal and contextualized discussions. So you really, by using the tangible and visual methods, it's easier to get your participants to tell you about concrete everyday actions rather than actions they felt they ought to do or they think that you want them to tell you about. And then also this possibility of working with a common consensus and giving participants in, for example, a workshop, a direct opportunity to involve themselves. So for instance, in the big drawing of our workshop, it was like a whole wall. It filled the whole wall, and the participants could go up and put their own post-its on there. And because we were drawing and we took drawing seriously, they were also invited to draw on their post-its if they didn't feel comfortable writing. Because otherwise in workshops, I find that often people find it a bit childish if you ask them to draw something. But if you draw yourself and you make that a valid language to communicate, then it's much more easy and fruitful to get people to play along, or how do you say it? So this is my last slide, and it's just, well, a time to reflect on why it can be so difficult to engage older adults in health interventions. I mean, it's easy enough to engage affluent, resourceful, physically active elders. They will come, no worries. But if you want to engage marginalized or minority elders or elders that live in disadvantaged communities, it can be difficult. But first of all, I think it's valuable to reflect on why we want to involve people and who benefits from it. So if we do it just because it looks good, for instance, in a funding application, and it then in the project just becomes a box to tick. So, okay, we went out in the community, we showed them a poster of what we're going to do, and they nodded, so we involved them. Yes, tick the box. Then, in my opinion, you really miss both aim and target. So I also think we need to be very aware of who we are working with and develop research interventions that are relevant and meaningful for them to be part of. So this can, I mean, they can be by providing positive community spaces or activities. It could also be to facilitate a platform where people can be part of changing their community, either on organizational level or physical level. And there are many different approaches, but it's key that the people we are inviting to participate get something from it. So it doesn't become just milking the cow, or that we just benefit from them. And it's also important to prioritize time and resources, because such a research really takes time, and it takes time and effort to establish networks, especially in disadvantaged communities. And these relations are an important deliverance in themselves. And as I also discussed in my recent paper, recruitment, time and resources, and fundings are primary challenges in carrying out these participatory health research projects using design-based research methods. So in my experience, visual and tangible methods are key in producing innovative and context-based knowledge. And I think it's an area that could definitely be explored much further in health research. So thank you. And the text on this, on the moon here, is, I can't sleep at night, so I'm counting the stars and thinking when I can see my family in Turkey again. So basically times of the pandemic and of feeling alone and missing your family. Maybe a bit down, depressing way of ending, I'm sorry, but